Dr. Isabelle Amig. I'm a rheumatologist and I have a practice called Unabridged MD in Denver, Colorado. I see patients on telehealth and in person, although I do prefer in person. I'm going to share a story today. And if my patient is here listening, this is for your husband. One of the inflammatory arthritis that we deal with as a rheumatologist is called gout. Gout is a very inflammatory arthritis. It's the worst pain. You wake up with the big toe, extremely red, painful, swollen. Even the touch of a sheet is extremely painful, okay? That's the worst. And then it can actually lead to chronic arthritis where there's no in-between episode where you're fine. So, at the beginning, maybe you had a little bit episode here and there, maybe once a year when you're doing a lot of eating of red meat or seafood or, just a lot of beer. And then after a while, if you don't take care of it, you can develop erosive arthritis. And so the story is that my patient is doing really well from her perspective, right? My patient, she's taking care, congratulations on the work that you're doing. By the way, really good. I'm so proud of you. Yet her partner is having so much pain, but would rather not see a doctor. This is for you, right? If you have gout, don't let it go untreated. What's the issue with gout? Gout is you either make too much uric acid or you don't get rid enough of uric acid. So, for example, someone that has a kidney issues is going to build up too much uric acid and it's going to stay in you, right? So you can have too much uric acid because you're not getting rid of it, or you're eating too much high-purine diet. That's what we call high-purine. So it's basically a lot of protein that when they break down, and that basically leads to a lot of uric acid. And after a while, you can develop tophi. Tophi are nodes that you can have under the skin. We have them here on the external surface of the elbow. You can have some on the ear, which I find interesting that there are some whitish nodules there, like just white spot that you shouldn't have. And then you can have them everywhere, on your fingers, you can have them on your toes, and so on. And what it is that this is a buildup of uric acid, and it's kind of like reservoir of uric acid. If you have this, then that's just really a sign that your gout is fully uncontrolled. And what happens when you're doing a tough man, I'm going to call this the tough man syndrome, because you men, can handle a lot more pain in general than women. I'm saying this because I see it in my practice. I do think that women take care of our bodies a little more in general, but when we have pain, we ask for help. Whereas men are like, no, I'm not going to ask for direction. I can figure this map out. The problem with gout is if you're trying to take care of it on your own and you've looked at internet and you're like, okay, if I don't eat this, if I don't eat that, if I take this, if I take that, if I take some anti-inflammatory, sometimes that works and that's great. So you can eat a low-purine diet, wonderful, excellent. The problem is that is not sufficient. And then why continue to have pain? Why would you continue to have this inflammation that's causing issues in your whole body? Because yes, you're a tough cookie and you can deal with the pain, which I'm so impressed by you for dealing this pain. Like, we literally learn in medical school that this is the worst pain anyone can ever have. So kudos to you if you can deal with that pain. But it is not worth it. And what I mean by that is that yes, there's the pain, but there's also all of the things that are being done due to the gout. It can build up in the skin. It can erode your joint. So you can actually have erosion of your joint and then deformities of your joint. So we're not just talking about pain here. We're talking about disability and the ability of using your joints. That's a problem, right? Then it can actually cause issue with your heart. We know now that high level of uric acid is not good for your heart and your vessels. I mean, that's number one reason why most people die is a heart issue. Like, it's one of the top 3 cancer, heart disease, some of the top 2 medical conditions. And we can prevent that. And then finally, it can cause kidney issues. So it can, like I told you, when you have kidney disorder, you can develop gout, but at the same time, that actually causes kidney issues. So, maybe you have had a urinary stone that's extremely painful. Well, those urinary stones are due to this buildup of uric acid. So my question is, why not ask for help when rheumatologists can help you? In my practice, overall, within 4 months, we put patients in remission of their gout. Our goal is to lower uric acid to less than 6, usually 5 milligrams per deciliter if you have tophi. Why? Because if you have those nodules, we know that you have more reserve and we need to take care of that. And it's going to take a little bit more time to make sure that you don't have flares when you have tophi, and the goal is to get rid of those tophi. The thing though, and that's the problem in the vast majority of cases, and this may have happened to you, the thing is that very often in primary care setting, especially right now where they have only 5 minutes to see you, they forget to tell you, and maybe they don't know themselves, it's totally possible, that if we move the uric acid, you will develop flare. Most likely you will develop a flare. So the typical example is, I'm coming to see my primary care physician saying, I have gout, my toe is super inflamed. Maybe we checked, uric acid is very high. Maybe we've checked, we know you have tophi, so that's a definitive diagnosis. Or maybe we've taken fluid out and saw the uric acid crystal. You're coming to your primary care physician or even the urgent care or even the emergency. And what they do is they're like, oh, your uric acid is super high, we're putting you on allopurinol. And then you develop more flares and more pain because they forgot to add something to stop the flares. And that is the issue. You cannot just give yourself allopurinol, moving the uric acid up when you're eating a lot of red meat or like anything, high in protein, up or down will cause potentially some flares. Any movement, right? And so then what do we do in rheumatology? One of my patients who came in not so long ago, well, I think it's been 6 months, he's doing really, really well now. He had this really severe gout. He had pain everywhere and he couldn't do anything. And basically what we started doing is that we said, okay, we need to decrease the uric acid because it's over 10, it was 12. We absolutely need to decrease this. And at the same time, every time you have a flare, we are going to prevent the flare. We're going to give you, in this case, we are giving colchicine. Some people can give anti-inflammatory. And if you have a flare, you need to let me know. You can also, we can give the idea. If I don't know the patient, I will start allopurinol and add colchicine. And so it's once a day unless there are contraindication and there are, adjustment. And then what we say is that if you have a flare, you take 3 tablets one day, the next day you take 2, and the day after you take 1. The truth is that sometimes you can still have a flare despite that. So then we have other things that we can do. That's really important because we need to adjust the allopurinol dose and decrease the uric acid. So we check uric acid every 2 weeks. And we go up on the allopurinol depending on the uric acid. So every 2 weeks, we have a blood work to check how much is the uric acid, because our goal is less than 6 or 5 if you have tophi, right? And that's where it's so important to have your rheumatologist at your fingertips, if you're texting or on the phone, is that if you have a flare, yes, you can, do the 3-2-1 of colchicine, but we have other options. Sometimes we give a little bit of prednisone, which is steroid. Sometimes we give a little bit on anti-inflammatory. We can take care of those flares so that you don't have all of those pain. And the goal is for you to reach the full goal of uric acid. Once we reach uric acid of less than 6, after a while, you may still have a little gout flare, but normally after a while, you have no more flare. And then after 4 months of no flare on both in this case, colchicine and allopurinol, then you can back off from the colchicine. So now you can see, right? Like the goal is then, if you have tophi, if you have those nodules, the goal is that those have to go away completely so that there is no more reserve of uric acid, too much uric acid. And so sometimes It takes a little bit more time because those are actually going to melt. And as they melt, they need to go somewhere, and sometimes it can cause a flare. So same thing, we're going to take care of this as well. Since I have this practice on Average MD where I can see patients every 2 weeks, I can talk to them closely, right? When this patient who had a uric acid more than 12, normally, if I had been in a previous practice that was insurance-based, I probably would have offered them something called Crystexxa, which is a biologic that's very, very, very expensive, but works really wonderfully by melting the tophi. But one, it can be associated with some pretty severe reaction. And two, it's super, super expensive. And then three, it's IV, it's a biologic. So, there are consequences to that. As a physician, I have a full plan of this is gonna, if this doesn't work, what do we do next? What do we net next? And I know where I'm going. I usually share this with patients from day one. I try not to overwhelm patients. We're gonna try allopurinol. If that doesn't work, we'll go to Crystexxa. If that doesn't work, what do we do, etc. I was shocked to see that the uric acid went from 12 to less than 5 within 3-4 months. And the reason for this is that we adjusted the allopurinol every 2 weeks, which I could never have done in an insurance setting because we have 3-month waiting time most of the time in an insurance setting. Whereas now in this practice, I am making sure that I have the space to see my patients, and I, on purpose, don't take absolutely an infinite amount of patients. This patient basically is at goal uric acid. We started seeing his tophi melt away. We're taking care of this. I think as soon as he has no more tophi and that his uric acid is still at goal, we can actually start decreasing the allopurinol. And who knows, maybe just a diet, it doesn't need to be on allopurinol ever again because he will have taken care of all of his tophi and his buildup of uric acid, and maybe the diet at that point is enough. One message is to realize that we are almost in 2025. We have amazing treatment. Allopurinol, febuxostat, we know how to use them. It's a matter of helping you get to full remission of your gout. That is absolutely doable. And that may be a remission that's not with treatment forever, which I think is really exciting. And my plea to you is consider this, give for 6 months, a year to your rheumatologist and say, I'm going to try. What's the point of having pain if we can take care of it?